Hello, welcome to Surrey Hospitals Foundation's webinar series, exclusively developed for you, our generous donors. Thank you so much for joining us. I'm Yolanda Bauman, Director of Charitable and Legacy Gifts at Surrey Hospitals Foundation, and your host for today's webinar. Surrey Hospitals Foundation and our donors support our region's major healthcare facilities, which are Surrey Memorial Hospital, Jim Pattison Outpatient Care and Surgery Center, and the Chorney Alzheimer's Center. We also support dozens of other programs in our region that help residents from birth to end of life. In the near future, we'll also be raising funds for Surrey's new hospital that will be built in the Cloverdale neighborhood. If you've received care at one of our facilities, then you know we have an incredible team of professionals here, from specialty surgeons, physicians and nurses, to technologists, therapists, and many hardworking administrators behind the scenes. These webinars are a great way for us to introduce you to some of them. I'll introduce you in a moment to our speaker, but first a few quick notes. The presentation will be approximately 20 minutes in length, and I'll see you back here once it's done. We would really appreciate your feedback at the end of this webinar and ask that you complete a quick survey. These are exclusive offerings for our donors, and your feedback is so helpful as we grow this program for you. I hope you enjoy today's presenter, who is a fascinating person. I think you will enjoy his presentation very much. Today's presenter is Dr. Richard Cleve, clinical biochemist and clinical instructor at UBC. Dr. Cleve has a varied and interesting academic journey, which eventually brought him to Surrey Memorial Hospital. He started by studying plant biochemistry, and his fascination with the technology used to study plants resulted in him pursuing a master's degree in physics. And that resulted in more curiosity on his part, so he decided to work towards an MD, medical degree, as well as to apply technology and biochemistry to the human body, an investigation into diagnosing and treating human diseases. He eventually heeded the call, "Move west, young man," and came to Surrey Memorial. Dr. Cleve is now the head of both the biochemistry and the pre- and post-analytical departments within Fraser Health. He also serves on several provincial and national laboratory groups. From time to time, he pops into our foundation office, and we always look forward to his stimulating conversations, from what's happening in the financial markets to the latest news about research into infections such as COVID. I'm very honored to introduce you to Dr. Richard Cleve. Welcome.
Thank you, Yolanda, for that very kind introduction. It's a scenario that plays out dozens of times per day in emergencies and clinics around Surrey and around the world. We have, for example, a 73-year-old woman who comes to the hospital complaining a couple of days of feeling unwell, shortness of breath, and a cough. Not surprisingly, during a pandemic, of course, anybody would realize their first thought is this COVID? And while her symptoms are consistent with COVID, unfortunately, none of them are so confident that we can definitely call this COVID. In fact, in the majority of the testing that we do, we actually find out the patients have something else underlying and not COVID. Sure, we can do some regular tests. We can do X-rays and CTs and regular biochemical tests. And while these help with the prognosis of the COVID, none of these can be used to actually make the solid diagnosis of COVID. So instead, we're going to have to turn to the lab to do a more specific test. So the first question we have to ask is, where do you actually find COVID? Well, the most prevalent place you find COVID is in the lungs. Now, to get that specimen, you're going to have to take a camera, take a scope, put it down into the lungs, and collect a specimen. I think we can all agree, maybe a great specimen, but that's a terrible way to collect a specimen. The next most likely place that we'll find the COVID is in the nose, and this is the place where we most commonly will test. Due to swallowing of secretions, we also see COVID is present in the mouth and in the saliva. In fact, along with BC Children's Hospital, Surrey Memorial Hospital helped develop the saline gargle test. So in children, we're able to actually use a mouth sample instead of a nose swab. And if you're going to swallow it, the other place that it can go is all the way down into the stools. And while it's certainly a possible specimen, we really don't like to collect stool specimens, and so we don't use this as a practical specimen. Now, interestingly, the two most common specimens we see in the lab, blood and urine, don't actually contain COVID in very large quantities, and so it's not something that we can actually use. Now, one of the truths about lab medicine, and certainly one of the things I'm most commonly involved with in my job, is figuring out when things go wrong in lab testing. We know 2/3 of all lab errors happen before the specimen has even arrived at the lab. So collection is absolutely critical. If you were to collect a swab, for example, in the wrong spot and you did not have any COVID on it, the best test in the world is not going to be able to detect any COVID. And in fact, this actually forms the basis of the hesitancy the medical community has had to home testing of COVID. The tests actually work quite well, but we know people have difficulties collecting the specimens. And where that difficulty starts is where the COVID is actually found. The COVID is most common at the very, very back of the nose, in the nasopharynx. And so you have to get a sample probe quite deeply in. For those of you who have never had the sampling done, it's a very unusual feeling process as this swab goes straight into your face. And honestly, you'll feel like it's actually, you should have poked out through the back of your head by the time you've completed it. But it's actually not a terribly painful process. But what it is it does feel very uncomfortable. Some people will have a gagging sensation. And in fact, if the patient does not involuntarily reflex their head backwards when you're collecting a specimen, the truth is you probably haven't stuck it in far enough. So the doctor will put this in there. It's in there for a matter of just seconds. You give it a bit of a twist, you take it out, you package it up, send it to the laboratory for testing. So what are we going to test for? Well, there's 4 basic types of tests we're going to talk about today. Antigen, antibody, nucleic acid testing, both PCR, and the typing or sequencing assays. So the first of these we're going to talk about is the antigen testing. An antigen is a substance, typically a protein, which elicits an immune response. So these would be the proteins on the outside. The most prominent protein that we see on the outside is the spike protein, and these are the tall portions that stick out. In fact, if you look at a COVID molecule or protein under an electron microscope, what you'll actually see is a circle surrounded by little dots. And those little dots basically form what looks to be a crown, or in Latin, a corona, hence the name coronavirus. And the spike proteins are important for actually targeting the cells within the body, and so they stay relatively consistent. On the surface, you also see 3 other types of protein. Nucleocapsid, which is important for integration, or in other words, for the COVID to enter into the cells. In fact, the variants of interest that we're seeing, or variants of concern, all involve mutations of the nucleocapsid. So this is another protein which is very important. The membrane and envelope proteins are important for this creation of the COVID molecule, but it's really not of that important once it's actually created. So the nice thing about the antigen tests are that this is a very simple test where you do not need a complicated machine. And in fact, it works very much like a pregnancy test. So on the bottom you'll have blotting paper, which basically, much like when you put a bit of water onto your shirt, it will soak through and you'll get a larger and larger spot. So that's exactly what we do with this. We add our specimen onto it. We add a little buffer, which is water with some other salts and chemicals, and then that will just naturally wick through. And so as it wicks through, it will pick up the various components in the test. Now on the strip itself, there'll be an area where you have antibodies which are glued onto the test. And so these antibodies are something which actually bind to the antigen. And so basically if there's any COVID there, it will get stuck there. Meanwhile, we've added other antibodies which are attached to gold particles or other things that we can actually see with the naked eye. And so this binds onto a second spot. So if you have COVID, you get your antibody attached to the COVID, attached to the antibody that you can see. Now it's important we also have a control area just to make sure the test didn't work, and that control area will actually just bind directly to the antibodies. So we need both of them to demonstrate that it works. So what we have to talk about is when you can actually do the testing. If we constructed a timeline starting when you first got the infection, what we know is initially you'll have an asymptomatic period, which typically lasts 3 to 4 days. This is followed by a symptomatic period, and eventually you get into a recovery phase, and eventually it disappears. If we were to plot the amount of antigen present It will have an exponential growth at the very beginning until you actually start to get an immune system response. Now our test itself is going to have a certain limit where it can actually do the detection. And so you have to come across that point. And so the point where we're actually able to detect it is right around the start of the symptoms. Now one of the things you'll notice is that we actually reach maximum amount of antigen at the very beginning of symptoms. And that's because the immune system, as part of its response, will be trying to decrease the amount of infection there. And in fact, much of the symptoms you see, much like most other infections, isn't so much due to the direct COVID response, but it's due to the immune system trying to fight off the infection, which develops most of the symptoms. So for us, this is handy because we have maximum antigen present at the very beginning. But as the infection goes on, your immune system fights it off, the amount of antigen and amount of COVID particles will decrease. And so we know about 8 days after the start of symptoms, we see that this is decreased to the point where we can no longer see the antigen being present by the test. For most patients, they're still actually having symptoms at this point. And so if you present very late with your symptoms, we cannot use this type of testing. In fact, that is the biggest problem with this type of testing. If you test too early or too late, you're not going to be able to detect the antigen being present. Some patients have very low viral load, and so it never goes positive, so we get some false negatives. We also have problems with false positives. These tests work quite well. However, when you have an underlying prevalence of only 1%, even a small percentage of false positives can result in a very big problem. And in fact, at 1%, we see about half of the tests that are positive are actually false positives. So this then needs to be followed up with a test that's much more specific. The lines can be kind of faint and can be very difficult to measure. Sometimes we can see some mutations, although so far it hasn't presented a problem. And unfortunately for these things, while it works well when you have 1 or 2 patients, if you have an emergency department full of patients, this type of testing does not work terribly well. And of course, the biggest complaint that we have with these is if you don't do the testing properly, you don't get the very good results. Garbage in, garbage out. But because it is at a point where you have maximal number of particles, even a nose swab from the very tip of the nose can usually give you a good positive result. This test is not currently being used at any hospital in British Columbia, but Surrey Memorial Hospital worked with BC CDC, and in fact we were the site which validated this for use in the film industry for screening of workers in that industry. Some people have said this may be useful for travel in the future because this is a very rapid and simple test. You don't need any fancy machines in order to do this. But wherever you do this, you're going to need to be able to do that confirmatory test, which is a much more specific test. So if we're not going to look at the antigen, maybe we can look at the antibodies instead, which is the body's response. So antibodies are also known as immunoglobulins. So again, we'll look at the timelines. So again, starting at the point where you get the infection, we have the antigen response just as we saw before. And of course, what we're going to see is the development of antibodies. Initially IgM, which we can detect at about 10 to 12 days, and about 2 days later we can detect IgG, another class of immunoglobulins. So unfortunately for this one, we're going to be able to detect it not at the very beginning of your infection, but only once you're a little bit further. In fact, really what it tells us is that you had COVID rather than you have COVID. The other problem that we see is we have an extremely variable time course. The amount of production of these two antibodies varies tremendously from person to person, and even within an individual in the ICU from day to day we see huge variations. And so the levels really don't tell us anything. They don't tell us whether you're protected or not protected. The other problem is that we know it goes below our levels of detection after a few weeks to a few months, depending on the person and depending on the severity. And so unfortunately what it isn't able to do is say that you had COVID, say 6 months ago. And so as a practical thing, it's limited of utility. But from studies that were done in the first wave in both Switzerland and in the United States, we know that COVID looks like it's about 2 to 5 times as common as we thought it was, using these types of tests. And really this is what first told us that there's asymptomatic patients with COVID. We had more antibodies than we were expecting. And again, we don't know if any of these levels are protective, but it is the only blood test that we have available for COVID-19. And a little bit feather in our cap here at Surrey Memorial, we were the only lab in BC that actually had the capability to measure both antibodies against the spike and the nucleocapsid. Even BC CDC lacked that ability. But in use, because of the limited use, we never actually implemented the test here at Surrey. It's used in some limited cases where you're looking at a post-COVID symptom, for example, multi-system inflammatory syndrome in children. It's used for outbreak investigations and some epidemiological research. And Life Labs does offer this test available as a patient pay test. This brings us to the gold standard test, nucleic acids. So if you can imagine, in your nucleus of your cell you have DNA, and that's sort of like a giant cookbook for how to run the cells. Of course, that's very critical. You don't want to damage that. And so you create a photocopy, an RNA molecule, and the body actually uses that RNA or photocopy to actually perform all the functions of the cell. Virus actually contains the RNA, which is not a surprise. It's trying to make copies of itself. So one of the tests that you may hear about is RT-PCR. Reverse transcriptase PCR. So the RT portion is basically where we convert the RNA back into DNA. This is a technicality. It's because of the way the tests work that we need to work with DNA rather than RNA. And then we do the polymerase chain reaction. Now I'm greatly going to simplify this, but basically we take that strand of DNA we just created from the RNA, then we run the PCR reaction. And this creates a duplicate copy, and so we end up with the classic double helix. We'll then warm this up. This separates it into two different specimens. And so now we started with one strand of DNA. We've now got two strands of DNA. And so now we'll run the PCR reaction again. And we'll warm it up. And we'll now end up with 4 strands of DNA. And we can repeat this again and again and again, each time doubling the amount of DNA. And so this is the power of PCR. We're able to take quite literally a single copy of that RNA and create hundreds of millions of copies of it, giving us tremendous sensitivity. But we also have tremendous specificity because we're looking at very specific types of DNA. And so we will get that. But it also presents a challenge for us. If the virus were to mutate, that may actually change the targets that we're looking at for. So in the lab, we're constantly watching for this to make sure that none of these mutations actually affect our test's ability to detect the COVID. Like everything else that we've always talked about, quality of specimen is absolutely critical, but because we have such tremendous sensitivity, it's actually slightly less important to us than the other types of testing. But this sensitivity also leads itself to one of the big problems. For some individuals, you'll have little fragments basically of dead COVID. Unfortunately, this assay can't tell the difference between a viable COVID and little fragments of dead. So early on in the testing, or in the pandemic, we used to test patients after to make sure they had cleared the COVID. And this works for most patients, but some patients for weeks and weeks after will have this. We don't believe that these patients were infective. Instead, they basically had the dead molecules. And so we don't tend to follow up patients anymore, unlike the beginning of the pandemic. The other thing, of course, is we have no idea where you are in the infective course. This will pick up very early on or very, very late. So you have to be able to correlate it to what the symptoms are of the patient. So this is really the gold standard test. It's very sensitive, very specific. This is the test that we use here at Surrey Memorial Hospital, BC-CDC. We use this for all the patients who go into our COVID testing centers. We'll get this test done. This is also a type of test which we're hoping to work up for the airports. And in fact, Surrey Memorial Hospital did the workup for BC of a point-of-care device, a small device which is able to do this instead of the lab. And we've now been rolling these out across BC. The point-of-care device works quite well. It takes only about 15 minutes to determine the COVID. However, it is somewhat less sensitive than our lab method and significantly more expensive, which is why emergency patients and COVID testing centers continue to use us in the lab. One of the big concerns always around the world had been we initially had very, very little testing capacity. And so what we see back in January and February of 2020, at the beginning of the pandemic, it was taking us 3 to 4 days to get a result back. We're happy to say that we managed to acquire our own machine here at Surrey back around March, and after that point we were able to decrease 3 or 4 days down to about 1 day. Oh sure, around the beginning of the second wave, everybody started testing worldwide. We ran out of reagents, and so we unfortunately went back to 2 days. But now that our reagents have stabilized, we're back down to about a day to get these results in. And so this is really considered to be world-class performance, and we're very proud of the fact we've managed to get it back down under a day for the test turnaround. Now, there's one final test that you may hear about, and I know I've had lots of people ask me about, and that's the nucleic acid typing or sequencing test. This is a modification of PCR reaction, but what you do is you stop it at various points. And because where you know what point you stopped it at, effectively you can read what the exact genetic code actually stated. And so using that, you can actually figure out whether it is one of the variants of interest or not. But we don't do this test very often, and there's a few reasons. One of them is it's tremendously expensive, both in terms of cost and in terms of reagents. It also is a much slower test. So we would not be able to achieve a day turnaround time if we were testing in this sort of volume. Ultimately though, if you have COVID, you have COVID. Whether you have a variant or whether you have the normal variety makes no difference. And so it really doesn't change our management. So from an individual perspective, it really doesn't matter which one you have. So really at this point we use it for epidemiological purposes, but also if we see variants out there, we know that we're probably going to see a lot more cases and we need to prepare in the hospital. We'll stop elective surgeries, for example, to create room in our ICUs. So right now within British Columbia, we randomly select patients who are COVID positive to just determine whether it might be out there. We have had a few blitzes where we did 100% of the patients. And we did that for a week, and it determined that our random process did seem to pick up most of the variants. If we have an unusual outbreak or we're trying to trace where we know that there was a variant, we'll also test those individuals. Surrey Memorial currently does not have this capability, but in the coming few months, we expect that we're going to have this capability. And this will help us not just in this COVID era, but after COVID, we're going to be able to use this for other infections and other conditions as the need arises. So we've now reached the very end of this presentation, so hopefully we gave you some information on the different types of testing that were available, but also a reminder that really the biggest driver of quality in the lab is about getting a good quality specimen, which is absolutely critical in order to run the lab properly. So thank you very much for this opportunity to speak to you.
Thank you so much, Dr. Cleve. The lab is truly a fascinating and a very essential department within the hospital. And we are indeed fortunate to have you lead Surrey Memorial Hospital's Biochemistry Laboratory Department. I trust our viewers have learned something new and interesting today. We ask that you, the viewers, complete this brief survey to share your thoughts on today's presentation. It will take less than 5 minutes and will also help us as we continue to provide more webinars for your information and enjoyment. You'll see a QR code come up on the screen here in just a moment. You can scan it with your phone's camera or click on the link below this presentation to access the questionnaire. We always love to hear from you. If you want to discuss this webinar or have any other questions or concerns, please reach out to us at our number 604-588-3371 or visit us online at surreyhospitalsfoundation.com. Thank you again for joining us, and we hope to see you at our next event.